Hey everybody, Renee DeVersal here, Vave Chief Medical Officer. I'm actually going to be at another simulation week while this is airing. So I pre-recorded with our guests, Dr. Anthony Laporta, Dr. Brad Havens, and OMS2 Ryan Becker. But I would love for you to tweet me, LinkedIn me, email me, Renee at vavehealth.com, anything like that if you have questions for those three speakers. I hope you enjoy the discussions as I really enjoyed talking to these three guests. Also, our next Vavecast is going to be in January 2022. It's been a long and hard year with a lot of Zoom fatigue, so we're going to take a break and catch you first thing in the new year. All right. Well, thanks for joining us. First of all, I'm very excited to welcome Dr. Anthony Laporta. I met him back in July at the 11th Intensive Surgical Skills Training Week in San Diego. So he's a professor of surgery and military medicine at Rocky Vista University School of Medicine. He's retired from the U.S. Army as a colonel after over 26 years of service, having served in every aspect of military education and military command leadership. He's a member of the prestigious Department of Defense Elite Defense Health Board, which is a mouthful, also a member of the Trauma and Injury Subcommittee. Dr. Laporta has performed as co-PI on multiple DoD research projects, including the use of immersion training and the formation of stress inoculation to address hardiness, resilience, and emotional intelligence. He's authored over 300 peer-reviewed articles and presentations on surgery, immunology, military, and simulation. He just told me he is now the associate editor for military medicine. Very exciting. And he originally trained in surgery at the Medical College of Wisconsin and the University of Oxford in England. And then here's the fun fact. As an avid skier, he was the first American to run the Olympic torch for the 2010 Vancouver Games. So if that's not enough of an introduction, I don't know what is. Thank you for joining us, Dr. Laporta.
My pleasure. That was quite a gig to be the first American running that Olympics. So that was pretty cool. That was
very incredible. And you've done a lot of incredible things. And the inspiration for this particular Educast talking about simulation and then ultrasound education came from when I was able to attend the 11th, as you mentioned, 11th Intensive Surgical Skills Training Week, which I'd been told about it. And I've seen simulation. I've been to international simulation venues where the exhibit hall is just blood and body parts everywhere. But I had never seen something so realistic and so immersive for the learners. And so I was hoping you could set the stage with us by telling the inspiration, the genesis of this incredible experience for the students.
I was really struggling because I'm a very strong believer in the same education process as I remember it in the early 1970s and mid 1970s in surgery. The process that the special operations personnel in our military also use, and that is that you have to make the decision and you have to suffer the consequences to learn what the next steps are. If those consequences are good, you'll keep that in your decision tree. If those decisions are bad and you have a problem, you need to be able to change it immediately. So those days went by the wayside because at least half of the cases and the number of cases that you made the decisions on went away with the 80-hour work week. And then with the addition of the fact that nobody was left alone at night to make the decisions, the person who made those mistakes once and then learned from it and never made those mistakes again the rest of their life no longer existed. Instead, they never learned that it was a mistake, never learned the next steps good enough, because there was always a senior person there, not only making the decision, but utilizing the technical skill themselves. And we see that these kids are not prepared. Well, one day I was asked to become a military advisor to a medical school that now has the largest group of students in it that will be going into the military outside of the Uniformed Services University. And I didn't know what to do. So I asked a special operations friend of mine to, quote, whiz bang the students. And so he was whiz banging the students when he showed an operation being done on a chopper. Now it has been done for real, but back then it hadn't. And I said, geez, my colleague Barry and I were trying to do that for years. And he said, oh, that's fake. It's called the cut suit. And I had no idea. I'd never heard of it. I said, wow, I never said, what is that? And it was a skeleton being developed partially by the military and partially by strategic operations, which is where all of this happens, that has all the organs in it. It just so happened that 10 days later, I was at Special Operations Medical Association as my colleague, Colonel Steve Swan, was the JSOC commander. And down the hallway was a person who was being criked, had a cricothyroidotomy going on. And Colonel Swan and I were walking, and we started to walk the other way because there was such a big crowd. And the fellow being criked stood up and walked away. And it was obvious to me that that was not normal. And that was the cut suit. So I went running up and grabbed him. And I said, are you the cut suit guy? He said, no, I'm an actor. But that guy over there, Mr. Kit Lavelle, is the vice president of the company. I went running over to him, grabbed him and said, would you like to do this in a medical school? Well, what do you think his answer was?
Of course. Or maybe,
no,
I don't know.
This is a military thing.
Oh, got it. See, I have my educator hat on.
and he'll tell you to this day that he didn't realize if I was at the special operations meeting that maybe I was military. And a week later, he called me. And at that day, Mr. Lavelle and I realized that this was a special way to teach open surgery. And also a special way to put the stress in to utilize what's called habituation, to utilize the ability to get to a mistake and change your way of thinking about something without hurting a person. It just so happened that Mr. Lavelle was also the vice president of a major movie studio that had already started to help the United States military build all the villages in the countries we were at war with. And suddenly this form of immersion or experiential training was born. And when I saw the first one, it was a series of Marines and Navy corpsmen that were learning to go to Afghanistan as independent duty corpsmen and on ships as independent duty corpsmen. And it was real. It was so real, I was nervous. And I said, holy crap, we have to do this for medicine. I was a part-time, I had officially retired. I got talked into 4 hours a month at the medical school. After I saw that and I went back to the dean, I said, this is a 100-hour-a-week job. He said, you're hired. And the rest is kind of history and what's happened with that. Fortunately, we've been in just wild publication string the last 10 years because we've been able to show how much better this training is than the training where people only watch or PowerPoint. You take a third year or a fourth year medical student and you put them in an operating room, it's virtually no one that gets to do anything. Hell, in this time frame, if they walk into a person's room and say, I'm the student doctor, at least half of them say, well, don't touch me. It's not your decision what's going on here. So that's what all that interference has produced, which brings us to you. How do you train? Well, we're able to come up with a lot of other gimmicks, but to put a live human in a suit that has all of the organs in it, so you can use a knife on it, you can interact with the facial expressions. You can have the person screaming. There are 40 amputee actors that work for strategic operations. So you can put the prosthesis on, it squirts blood across the room. It is a phenomenal educational experience. What this has done is completely changed the pressure level on the students, and made it so that they understand when it was the appropriate decision, when it was not the appropriate decision, and taught them an enormous amount of emergency skills. And as you know, on Intensive Surgical Skills and Trauma Week, besides, I'm just thinking, I think it's 6, might be 7, might be 9 episodes of major trauma, because each day, so it's 9, because each day has a major mass casualty in the morning and a major mass casualty in the afternoon. Besides that, all day long, and maybe sometimes at night, there'll be the regular general surgery problems or psychiatric problems or heart attack coming into our artificial emergency room. And so we made it so you had to learn on the run. We made the training exactly like the training back then. And that's how we developed Kutsuit Weekend, was the beginnings of what we now see is an enormous way to train. I mean, we designed the mistakes into it. We designed that if you don't suture ligate the short gastrics, if you're taking a spleen out, they're going to bleed a little bit later, and you're going to have to come back in that room. We actually make the training that way. And it's very realistic. It's very humbling.
I also loved some of the components. So within those ORs, there was an anesthesiology staff member as well, or a student playing that role with an anesthesiology educator. So if they crank the blood pressure too high, if they don't allow permissive hypotension, there's more bleeding. Every little nuance is worked in there. And it was really incredible to see. And of course, as an internist, history is a big part of the physical and what you do with it. And so being able to have the Kutsuit in your triage with the history, what was the mechanism of injury, what are your symptoms right now, to help make those decisions, was really neat to see the students doing that.
Yeah, it's kind of fascinating because, of course, then you throw in the non-surgical abdomen, and then you throw in the person having chest pain. It's as real can be without being real.
And the other things I had noticed was that, so it's not just crank up the heat and let them boil. There were a group of, and I'm going to use the wrong term, but there were the support people. There were counselor type support people that are there. So there's debriefing. So afterwards, debriefing, and then debriefing of the scenario, and then debriefing of your reactions and your emotions and those things. I thought that was very interesting.
It dawned on us about 5 years ago that we all knew debriefing was important, and it has taken a long time for all of us as physicians to realize debriefing our emotions is at least as important on all of those types of situations. So our first endeavor into this was to attempt to study cortisol and amylase in fleet and forward surgical teams, the actual teams that are going to war in 2 months. Mm-hmm. And we did that, and I did that with Captain Tuan Wong and Mr. Lavelle and some others. And lo and behold, we come up with the same habituation patterns of the teams coming back from war that didn't go through the training. So we were able to show, and that's what the Defense Health Board came to see, that we were hormonally able to show that the training changed the hormonal pattern to that of people coming back to war, from war rather, from war.
Mm-hmm.
And that made us start to think a lot more about what the heck was going on and how much habituation we've been able to find out. We've now gone as deep into, with the first responder groups, we've gone as deep into identifying 40 different proteins and how they change. And we think we have some leverage. And Dr. Rebecca Risner, who of course you met there also, who's our epigeneticist and molecular biologist, and Amanda Brooks, who is our chief of research, have spectacular data that is literally being written up right now for the New England Journal of Medicine. We think it's that good.
Wow.
And so we're pretty sure we have a good handle on how to prevent some PTSD. And we have now shown with our military medical student group dramatic improvements in emotional intelligence and dramatic improvements in the resilience special gauge that Paul Bartoni developed for our special forces. That resilience gauge called the hardiness resilience gauge changes dramatically.
And again, I love that it's the 1970s, like surgical learning from your mistakes while also working on the hardiness, resilience, the other pieces too, trying to make this perfect, not perfect, no one's perfect, but to create the 2020 and forward person that, or, clinician that has the skills, but also has the resiliency.
I was probably the most humbled I've been in my life, although I've certainly had plenty of events to be humbled by. But when the person who did the 30 years worth of research for the United States military special operations, Colonel Paul Bartoni, came to Intensive Surgical Skills Week to see it and said, "This is the best training I've ever seen in my life." I mean, this is a guy who's retired now, who ran our defense university and is probably the world's foremost research psychologist. We can help people and we can make people better doctors. We can make them better people besides better doctors.
And fare better after everything that they see, whether it's helping in civilian trauma, military, anything. They're called on in many different ways. It's not just only.
Well, I think, we also have not published this yet, but we are in the process of writing this up, and we're either going to send it to Journal of the American College of Surgeons or Journal of Surgical Research. And we do have this on at the Wagenstein Scientific Forum, which is, of course, the most important young researchers meeting as part of the American College of Surgeons Clinical Congress. We have on that we were able to change the board scores rather dramatically. Step 2 board scores, we changed on USMLE by 5 points, 5%, I believe it was. And we changed the COMLEX step 2 by 17 points. Wow. I mean, those are, when you realize it's 4 days, and we compared the 110 people that we had put through Intensive Surgical Skills Week with 300 people, the person that was above them, with 200 people, the person that was above them in class rank and the person that was right below them in class rank. So we have a true pair of those that went and those that didn't at the same class rank, and those that went jumped dramatically.
So this is one example of a photo of one of the scenes. So we're getting ready to prep, and then we come straight through and they have to triage. So it's a combination of triaging the transport. So y'all have, or strategic operations, they will have the California Highway Patrol, the Border Patrol, other groups come in. So it's really a win-win in terms of when you're out here triaging who gets transported to the ED first, who's stable to move, et cetera. And then the students in the ER are accepting these patients and having to triage, as you mentioned, surgical abdomen, non-surgical abdomen. How do we progress from there? And then this was a person, one of the actors within the cut suit. So they're having to decide right there on that person. I don't have pictures. I didn't get one of the cut suit model in there, but this is resetting of the cut suit in one of the ORs.
Yeah.
And you can see this very realistic anatomy. I didn't catch. Here's a little spleen as he's resetting it. And then he's resetting the omentum. And then he's putting on out. And the students actually in the skin, they have to actually physically cut through it all. It's remarkable. And so to have that review on anatomy and everything else, and then I just had 2 pictures of them actually in the OR trying to be as high fidelity and, accurate to the realistic in the experience as possible. And so those were just a couple of the pictures that I wanted to show. And I just think it's really remarkable.
I think a point you just made is one we should probably emphasize a little more. And that is that this is the real training for the California State Patrol, the California Federal Fire. So their training is part of this. And my students are now our students, since there's multiple medical schools involved all of a sudden. It sort of went from a little mom and pop to wow. So the students play the patient, a first responder. And so they have to learn all the information of diverticulitis, for instance, and they have to learn that illness to present it to the next student who's the emergency room resident, but he's only a second-year medical student, who has to present it to the staff or to the senior surgery resident who's only a second-year medical student. They have to decide to go to the operating room. They have to play the nurse, they have to play the anesthesiologist, and they get all these rotations, and we can do 50 people a week. And they get to play all these things intensely, still have time for debriefs.
Yes. And they also get to do the skill stations.
And skill stations.
But yeah, this is just a phenomenal overview in the history, because I kind of saw the magic, but I've been wanting to learn a little bit more behind the scenes, how it got to be there, year 11. So
Should be fun.
Work. Yeah, very cool. I was really excited to be a part of it. So I appreciate your time.
Oh, no problem.
So I'm really excited, first of all, to introduce you all to Dr. Brad Havens and OM2 Ryan Becker. So I'm going to tell you a little bit about them, and then they're going to tell us about this project that we worked on recently. Ryan is a second-year osteopathic medical student at Touro University, Nevada. He was raised in Henderson, Nevada, after which he attended the University of Nevada, Reno. He then matriculated into the TUN, Touro University, Nevada, DO class of 2024, where he's working with his research mentor, the illustrious Dr. Bradley Havens, MD, on ultrasound education in the military. As an Army HPSP student, which I'm going to make him explain to you, he's excited to continue working to improve military medical education and serve a fulfilling career as an Army physician. So that's Ryan. And now I'm going to tell you about Dr. Bradley Havens, who's a graduate of the University of Nevada, Reno, where he received a BS in biology. He then went on to graduate from Wake Forest School of Medicine and also received the Health Professional Scholarship Program through the U.S. Army. Dr. Havens trained in family medicine at Fort Belvoir Community Hospital in Northern Virginia. He then served in various duty stations such as Fort Campbell, Kentucky, Camp Buring in Kuwait, and Fort Meade in Maryland. He's worked as a hospitalist, primary care physician, and clinic medical director. Additionally, Dr. Havens has been on the adjunct faculty for the U.S. Army PA program, the Walter Reed National Military Medical Center Transition Year program, it's a mouthful, and the Uniformed Services University Doctorate of Nursing program. After serving 7 years in the Army, Dr. Havens returned to his hometown of Las Vegas and joined the faculty at Touro University, Nevada. And that is where our paths crossed. And so now I'm going to kick it off to you, Dr. Havens. And if you're okay with that, I'm going to call you Brad after this. Ryan, I'm going to call you Ryan. Feel free to call me Renee. So I would love it if you could tell everybody how we came to be sitting here talking about this study.
Yeah, so thank you, Renee. That introduction is wonderful and much more than I feel like I deserve. But our paths first crossed at Turo, Nevada. So Turo University, Nevada was looking to integrate ultrasound into their preclinical curriculum. So they partnered up with the company you work with, and that's where we met. And upon seeing the Vave device, I thought, wow, this is a great device, a highly portable, battery powered point of care ultrasound machine that has, a ton more applications than we're currently using. And then to get more specific into the research, so I'm involved in a week-long intensive experience for military medical students called Cut Suit Week, which I think you'll talk with Dr. Laporta about more. But a lot of research gets done at that event. And I thought, hey, why don't we do some research using the Vave device and the educational component, which is kind of unique. So most of the ultrasounds that I'm familiar with don't have an integrated educational component like the Vave app. So we wanted to do some sort of research study to see essentially how well does that work compared to a traditional method of learning.
And I love that idea because one of the things for me is I helped to guide and create modules and things that I thought helped teach medicine in a unique way, more anatomy, physiology, et cetera, but also teach ultrasound while doing it. But it's really easy to be inside the echo chamber of your own head and say, this is awesome, this is cool, we should do this. And there's actually not a ton of great data saying, or really any great data saying that ultrasound is superior in terms of teaching these other tasks, or the different ways that we teach ultrasound, that one is more superior or non-inferior than the other.
And it's great that you use that word non-inferior, because when we were coming up with ideas of how we could do the study, and I just have to say that I really appreciated how hands-off you were, because I didn't want there to be a conflict of interest between the research component and the Vave company itself. We wanted to make sure that there was no conflict of interest there. So when we set it up as a non-inferiority study, because we knew we weren't going to have the numbers, so the N, to give us a power, to give us a superiority study. So we designed the study as a non-inferiority study.
How did you end up connecting with Ryan? I'm curious. And how did you end up pulling in students? And what is your research mentorship like there?
So I'm on the core faculty of Turo University, Nevada in the primary care department. So I'm always looking for relatively short-term research projects to get students involved in. Medical school is not the greatest time, I think, to be taking on very large research projects, because the students' time is under so many demands already. So I like to get things done over the summer, preferably between the first and second years. I'm a club advisor as well to the military medicine interest group. And because this was a study that was going to be done at Cut Suit Week, I thought that this would be a perfect fit to have our military medical students perform some research and give them an edge when applying for residency.
I love it. Perfect. So military medical students, that's bringing me back. I sort of snuck it into Brad's intro, but Ryan, could you tell everybody, us civilians here, what does HPSP stand for, and how did you end up being in this program?
Certainly. So the HPSP program is the Health Professions Scholarship Program, and it's a program that goes across multiple branches, but I chose the Army one just for training opportunities largely. And so what I'll do is I'll get my school paid for, and I get a stipend while I'm attending Toro University, Nevada, and I'll owe them a commitment of minimum 4 years after I complete my residency, which will be done at an Army facility. And so that's the basics of Army HPSP.
So next, we're going to have you tell us, Ryan, what went on before I ended up showing up with the extra Vave devices, and the teaching component that I did is service back to this Cut Suit Week. So can you tell us the structure of the study?
Briefly, there were two groups that were being studied. So we split half of the cut suit week participants into an education where they got the POCUS basics through strictly a PowerPoint. And then we had the other half of the cut suit week students that were trained using the Vave Health point of care ultrasound or POCUS modules. And so we split them in half, and then we gave the students the opportunity to get tested on their POCUS or point of care ultrasound skills by getting tested in 4 different views. So the 4 views that the students were required to obtain an adequate view of via ultrasound was the right upper quadrant, the left upper quadrant, the suprapubic region, and the subxiphoid region. And so the students all took turns getting a view of that using the education they'd either gained from traditional PowerPoints or from the Vave modules. And so after comparing the results, we were able to determine if the Vave modules were in fact non-inferior to the traditional ultrasound PowerPoint education.
Cool. And so what did you find?
Certainly. So we just finished our results. And so overall, the Vave ultrasound modules were non-inferior to a traditional PowerPoint education. And so that's like the general assessment when we viewed all 4 of the scores of the students put together, the score of all 4 of the regions. And so in total, it's non-inferior. And then we also did the same comparison between each view. And so for the right upper quadrant, the left upper quadrant, and the suprapubic region, those regions were also all non-inferior, contrary to the first 3 views. For the 4th view, or the subxiphoid region, students that use the Vave Health POCUS modules performed less proficiently in obtaining the subxiphoid region.
Got it. Yeah, that's some xiphoid.
And so overall, the students that used the POCUS modules from Vave performed non-inferior to the students using the traditional modules.
Very cool. So I'm going to kick it back to you, Brad. And I always like to talk when I'm teaching, about like the 3 POCUS pillars. So image acquisition, image interpretation, clinical integration. These are students that are, they're preclinical students. So they're before the summer of their 3rd year. So we kind of had left out the clinical integration piece other than some quizzes in the app. And I was curious how when you were conceptualizing, okay, small group of students, how I'm going to assess them, what were your thoughts, or how you kind of sussed out what you wanted to look at?
Mm-hmm. So given the time constraints that we had with the study, we only had one evening from the study. I thought it would be best if we focused on one of those 3 pillars, which was image acquisition. To add in image interpretation and then clinical integration would have just been too much for the time that we had allotted. So we decided just to use image acquisition. And if I could get slightly more into the methods. So after we had the images acquired, we actually had them graded by 2 different fellowship trained physicians who have somewhat fairly recently done ultrasound fellowships. So one of them works in Arizona, and then the other one is an emergency medicine physician at Children's Hospital up in Seattle.
Very cool. And so how did was it and either of you can take this one, was it a 1 to 5, no identifiable structures, or 5 out of 5, perfect image? Just curious. Or was it simple binary, clinically useful image or not?
Yeah, so we asked the graders to grade on a 1 to 5 Likert scale, and kind of gave them some benchmarks for grading. So 1 would be no identifiable structures in the image, and 5 being kind of an ideally captured image. Mm-hmm. We did have a lot of, not surprisingly, with a preclinical student, images that were taken backwards or upside down. So those were all graded appropriately.
Got it. Cool. So one thing I wanted to do is going to show a couple of quick little pictures here to kind of set the stage as well, really round it out. So again, the whole concept started, the dean, Dr. Gilliar, and the faculty and the leadership had said, okay, we're gonna do this. We're gonna get a probe for every student. And then with that, it comes as an educator, I think, well, a device is a device, but if you don't know how to use the device, or if you don't have the trained faculty to train with the device, it's not enough by itself. And so we had then set up and came down and did some train the trainer time with y'all. And that was where we had first met, Dr. Havens and I, was when we were like, okay, you all have done some in the past, or maybe none in the past. Some of the anatomists and physiologists hadn't done any, but let's train everybody up to a certain level of knowledge so that when the students come in, you're all ready to rock through these labs together. This was just when that first time when we were down there, we were training up some of the students as well for some near peer. I love student super users. Near peer students are really fantastic for teaching. And some of your third and fourth year students have already been jumping in on this. But once we then had done this kind of train the trainer hands-on stuff, we then thought, okay, what's the next way to make it so when the student walks in, they're ready to go? As hands-on trainers or as expert faculty, your time is best used at the bedside with the student, teaching them the hands-on skills. And so how could we deliver it? And so this is where we got through into this MedEd app. And I remember showing you this down at Toro and kind of showing one of the videos and having this chat like, wow, this really actually could be useful. Could we help students learn to scan faster? And then was very, totally jumped at the opportunity when you said, I've got the perfect place to study this. So, and then the payback part, like for us, you already had your students had the probes, like we didn't have to supply equipment or anything. But my payback for this was to come down and teach, which is my favorite thing to do in the world anyway. So just threw in a couple of pictures here. So here's a Brad and myself. And so each of the students, they have these really cool skill stations, needle decompression, bedside decompressive thoracotomy, crikes, all kinds of stuff, because these students will eventually be deployed. And I love the message Dr. Laporta has told us about what his vision was with this, but we wanted to add in a standard ATLS tool to their toolkit, making sure we're covering it all. And so we were just able to be there, so teaching together, and they all had to get signed off on it. And so they had to scan on each other to get all of the different views. And then also the Toro University of Nevada PA program, or the simulation center rather, had loaned this really fantastic Phantom so that we could then have them go from normals over to abnormals. And here, even you could see the ribs. So when I tell them to rotate the probe marker 5 degrees towards the back, it makes sense. Oh, okay, the ribs are there. And so I just want to show a couple of pictures about what went on after the study portion to try to give them some education in addition to their couple of hours of extra time they spent being, consenting and participating in this study.
Yeah, no, I think the study and having point of care ultrasound there and you as an educator was very well received by everyone. The students seemed to absolutely love getting some more hands-on experience with ultrasound. It seemed like most of the students had some experience in the past, at least a conceptual knowledge of ultrasound. But really the hands-on skills is what they needed some assistance with. And so we got a lot of hands-on time with our students. And I think it's important to say some of the faculty at Cutsuit Week as well, who are all incredibly well qualified. I feel like I don't belong there with my qualifications because of how good of the quality of physicians they have as faculty at Cutsuit Week. Some of them actually approached us and wanted some ultrasound education as well. So we did that.
Some wonderful senior people were learning and really embracing it, which was really fun. So, so Ryan, my question for you. So we have a non-inferiority study of let's say, interactive app-based education versus kind of the gold standard of the PowerPoint. COVID days, we're all saying death by PowerPoint. So what are you thinking of for, I realize you're in your second year now, but what are your thoughts for next steps? I'm putting you in the hot seat now, and you can kick it to Dr. Havens if you need to.
Next steps in terms of the research study, I'm assuming.
Yeah, or future direction. So when you write this up in the discussion, you're going to have to say limitations and future direction. So how might you, sorry, I'm really grilling you here. How might you think about those things?
No, it's no big deal. So there were some limitations that we found with the study. One of the main ones was like the subject bias. So some students may have had different preclinical training compared to other students that attended. And so maybe that we need to probably control for that next time. Another one was like the inner reliability between graders. So we tried to mitigate that with a rubric. So the two graders could use objective ways of measuring the students' scores and assessing them on that Likert scale that Dr. Havens mentioned. So there's always going to be that, and that's inherent, but we're looking for other ways to be able to mitigate that as well if possible. And then lastly, we did have some students that did drop out. And so that always tends to be an issue when you're involving study participants. And so we'd like to make sure that we can retain more students, and then in the future, probably increase the sample size just to improve the power of the study.
Exactly. I was really impressed. These are long, long, long days because I was able to see Tuesday, Wednesday, Thursday, and it is hot, and they're doing high stress, high emotion work in these very high fidelity simulations. And so the fact that any of them were willing to spend 2 more hours getting, ultrasound quizzed, or, having to go through the OSCE type image acquisition setting, I was very impressed with. Any other thoughts on future directions for you, Brad? So I agree with Ryan, definitely trying to increase sample size. One thing that's hard is that we can't, now that we've rolled out, every third year student, every second year student will have devices at the institution. And so how do you say, okay, y'all get modules and y'all don't? If we're calling it the gold standard for your curriculum, how do we actually assess it better? So I don't have an answer.
Yeah, and I don't have an answer for that either. I think further research clearly always needs to be done. I mean, I think as physicians and researchers and scientists, we should never stop exploring what possibilities are out there. I don't see the students at Turo, Nevada as an ideal study population, just because they've already had exposure to point of care ultrasound. So wouldn't want to unbalance the curriculum for some students. So it would be very difficult to have a null group. I see a potential for research in an ultrasound naive population. So I think this would be a great tool to push down to first responders. So paramedics or EMTs in the civilian world, and medics or corpsmen in the military world. And if we could somehow intervene in their educational process and have an ultrasound naive study group or an ultrasound naive population study, I think we would get a great wealth of data from that population.
Yeah, I love it. I think a lot of the enthusiasm, if I just reflect back on the past, 10, 15 years of ultrasound medical education, there's so much enthusiasm and it's so fun and the students love it. So it's really exciting. It's easy to say this is better. It's gotta be better, right? But I was just really happy when you were like, hey, well, let's actually assess this. Let's see if this is better than the gold standard or non-inferior to the gold standard, which the gold standard is a gold standard for a reason. So in the old days before PowerPoint, it was the slide projectors. I'm sure Ryan doesn't even remember that, but the classic presentation model. And so the hope was if you make it in-app, like Uber worthy, like you're waiting for your Uber, like that amount of time, these little chunks, digestible chunks. So I just really appreciate, both of your time. I had a blast teaching at that session, and actually have been able to go back for some of the fleet surgical teams, so teams that are going to be deploying and need to know that the EFAST exam is part of ATLS. And so it's opened an entire educational world for me. And so I'm just really thankful for the experience and being able to connect with you two and see and observe your research.
Well, we appreciated all the support that you gave us, helping design the modules. I know you had to modify your timetable for app development. So we thank you very much for that.